Guys, now let us start one of the most feared topics in ophthalmology. Yet, I will say one of the easiest probably in ophthalmology. Am I being confounded here? I'm saying easiest. Retina is written on the screen. Is it easy? Yes, it is easy. I say everything is easy. That is my job, guys. I want to make it easy for you. And yes, actually, it is easy. But we fear it because we haven't read it. During our third, first, or our pre finals, everybody in ophthalmology, we are in a habit of seeing the volume of the chapter, counting the number of the pages. And when we end up counting the number of pages in retina, it's a very, very, very long chapter, guys. So we invariably don't read it completely. We go to our seniors, everybody. We get the high yield topics marked and we just read them. Probably 4 or 5 topics like diabetic retinopathy, retinitis pigmentosa, and some other topics, everybody. And that is where life becomes difficult for us, guys. We haven't put enough of our time to read it. And that's what we are going to do here. We are going to be slow, we are going to be methodical, and we are going to make retina easy for us from now on, everybody. Yes? So let's start with what we already know about retina, guys. What we already know through the various chapters that we have already read, through the various videos we have already seen, and mainly the basic anatomy of the eye video, the first video that we have seen, everybody. What is the color of retina? We know that the color of retina is not red. Instead, it is transparent. We know this. How many layers are there in the retina, everybody? We haven't discussed the names of the layers, yes, but we know that there are how many layers in the retina, everybody? 10 layers. Then gross anatomy we have discussed in detail. We have seen that there are 3 parts. Optic disc. We have seen the anatomy also in glaucoma, everybody. We know that the central vision is given to us by an area called as macula. The center of macula is fovea. And we know that the third important part in the gross anatomy of retina is ora serrata, the anterior termination of retina. Yes, all of this we already know. We also know that retina is a part of the fundus. We know that fundus is a view of all these structures in the posterior segment together. Yes, so all these broken pieces of information we have read previous to our retina videos, right, guys? Now, what we want to do is we want to be able to see the gross anatomy in a fundus image, everybody. That is what we are going to do. By the names we know, we are going to visualize a fundus image, everybody. So let's see what a fundus image looks like. So this is a normal fundus image. Now, whenever I look at a normal fundus image or any fundus image, first of all, I want to locate the optic disc because that is the most easily visible structure, everybody. So can all of us see a vertically oval or a round optic disc? If we remember, in the center of the optic disc, everybody, there is a empty area optic cup. Through the optic cup, as you can visualize here, the vessels, everybody, come in and go out. Yes. Now, this much we already know. Okay. Now the point comes, where is the macula? Macula, how do we know where is the macula? So first of all comes the theoretical point. The theoretical point is macula is situated, anybody? Where is macula situated? Macula is situated, yes, macula is situated temporal to optic disc. Okay. So that means we need to focus at the optic disc and then we need to see temporally. But which side is temporal? Is this side temporal or is this side temporal? How do we know in a fundus image? So for that, we need to focus on the blood vessels coming out of the optic disc. We will see that some of the blood vessels are going linearly, everybody. Wherever the blood vessels are going linear, obliquely, that is the nasal side. And wherever the blood vessels, as we have drawn, everybody, superior arcade, inferior arcade, that means they are forming an arc superiorly and arc inferiorly. That is the temporal side, everybody. Yes. So we know that this side is our temporal side. So somewhere here my macula must be situated. Now, how do we look at the macula? We trace all the blood vessels. See, I am tracing all the blood vessels for you guys. Yes. Inferiorly, superiorly. Let's just see, everybody. I'm tracing all the blood vessels for you. Now, when I've traced all the blood vessels, in the center, everybody, we get a part which is relatively avascular. Can I say, everybody? Yes. So in the center, we get a part which is avascular, and when we focus at this part, we know we are looking at the macula. I hope I'm clear on how to see a fundus image first of all. Yes or no? We see the optic disc, we see the arc of the blood vessels. The arc of the blood vessels makes the temporal side. On the temporal side, in the center, we will find a avascular area, everybody, where there will be no branches, nothing of the blood vessel, and that is my macula, or that is my fovea, everybody. Yes. I hope we remember that the center of the macula or the center of the fovea, there is a zone called the foveal avascular zone, everybody. I am not saying that the macula is avascular, but a certain central part of that foveal avascular zone, or FAZ, is avascular, and that is helping us identify it in a fundus image. Right, guys? I hope we are clear about this. Why do we need to be able to see all this? Whenever we are looking at any diseased fundus image, everybody, any pathology, we need to be able to ascertain where is the pathology first of all, whether it is in the optic disc, whether it is in the macula, whether it is in the periphery of the retina. I hope we understand this. Now, to remember this, let us draw a diagram, everybody, line diagram. So I draw the optic disc. In the center, I draw the optic cup. Then we have the blood vessels, everybody. Now I hope you understand, wherever the blood vessels are forming an arcade, that is the temporal side, the opposite side becomes the nasal side. Then there will be lots of branches of blood vessels coming here, there, everywhere. Yes or no? But in the center, as we said, there will be an relatively avascular area, and that is what I'm writing as M macula. Avascular. Okay, everybody, we all remember that this is our optic disc. This is our optic cup, and the periphery, everybody, which is pale pink in color, pale orange or pale pink, everybody. This part is, what is this, everybody? Neuroretinal rim, NRR. All this has been discussed. I hope you remember very clearly in the basic anatomy of the eye and in the glaucoma chapter for the anatomy of the optic disc. This is what you will keep in your mind to be able to see every image of the fundus. Right? Now, this is your basic reconciliation of what we have already read. Yes? Now what we need to read, everybody, is the microscopic anatomy of retina. When I say microscopic anatomy, what do I mean to say? I mean to say we are talking now about the layers of the retina. Yes, gross anatomy we know, done. Microscopic anatomy, layers of retina. So how many layers are there in retina? We know, everybody, 10 layers are there in retina. Now, as I've always said, that the layers need to be always read from anterior to posterior, guys. Yes. So when we were reading the layers of the cornea, I hope you remember we read from anterior to posterior. This was our cornea. Yes, you are looking at my cornea. So this is the anterior layer, outermost layer. This is the posterior layer or the innermost layer, everybody. But when we are talking about the retina, everybody, this concept gets flipped out. Let's see how, everybody. Let me draw cut section. This is my cornea. This is my sclera. Okay, just a very rough diagram. This will be my iris, ciliary body. This will be my whole choroid if I'm drawing it very roughly, everybody. And now this will be my retina. So let's say I'm drawing the retina like this for you. Okay. Now, if I focus on the cornea again, everybody, this is the anterior layer or the outermost layer. This is the posterior layer or the innermost layer. But what about the retina? What about the retina? Everybody, let's focus this point, everybody. This is the anterior layer. This is the posterior layer. Now, if I ask you, where is the anterior layer of retina, everybody? Is the anterior layer of retina outside the eye like cornea? See, everybody, the cornea anterior layer is outside the eye. But if I'm talking about retina, retina anterior layer is it outside the eye or is it inside the eye? Yes, everybody, this is inside the eye. That is why I say the concept gets flipped, everybody. But the posterior layer is the outer layer, everybody, for the retina. Yes or no? So when we discuss the layers of the retina, everybody, we know that we are discussing from anterior to posterior, and that means we are discussing from the innermost layer to the outermost layer and not the other way around, everybody. Yes? So that means if I can say in another language, this is my vitreous. So my vitreous touches which layer, everybody? My vitreous touches the innermost layer of the retina. This is the outermost layer and this is my choroid, everybody. So my choroid touches what, everybody? The outermost layer of retina. I hope we are clear about it, everybody. Yes. So if we understand the organization, let's start discussing the names of the 10 layers of the retina, starting from inside to outside, everybody. So what is the name of the innermost layer of retina? Let's start. The innermost layer starts from eye. Eye for internal limiting membrane. Internal limiting membrane. I'm writing in front of it, everybody, that this is the innermost layer. Okay, please remember about this. This is a true basement membrane formed by footplates of Mueller cells. Mueller cells are structural supporting cells in the retina, everybody. I hope we know this. Yes? Now, the name of the second layer, everybody, starts from N. N for nerve fiber layer. I hope self-explanatory. We all know that the retina needs to have nerve fibers, nerve fiber layer. Then the third layer comes as G, ganglion cell layer. Moving on, everybody. Fourth layer, I for inner. See, we are talking about the inner retina now. Plexiform layer. Then again, I for inner nuclear layer. O for outer plexiform layer. O for outer nuclear layer. Okay. So now from inside we have come to the outer part of the retina, everybody. Outer plexiform, outer nuclear. Then comes external limiting membrane. External limiting membrane. Please remember about external limiting membrane that this is not a true basement membrane. This is not a true basement membrane. Please remember this. P for photoreceptors. And then the last layer, everybody, if we have come to, then P for pigment. And as soon as I write the word epithelium, I hope you understand that epi means outside. So we are talking about which layer of the retina, everybody? We are talking about the outermost layer of retina here. So these are the names of the 10 layers. So everybody, first of all, it is very important that we know the names of the layers of the retina, everybody, before we are able to discuss the functions of the retina. Because that is the main problem. Usually students skip reading the names of the layers. They think, who will ask? Yes, I know nobody is going to ask you straight away the names of the layers of the retina. But a lot of concepts, a lot of the pathologies, you will be able to remember because you remember the names of the layers of the retina, guys. Yes? So, how do you remember this? There are lots of mnemonics, everybody. What I like to remember it is like this. Everybody, the innermost layer, I. Then nerve fiber, then ganglion cell layer, ING. Okay, what is ING, everybody? ING is a suffix, everybody. What am I doing right now? Talking. What are you doing right now, everybody? Listening. What are you doing, everybody? You are seeing a video, everybody. So ING, yes. Then comes inner plexiform, inner nuclear. So I can write I2. Then comes outer plexiform and outer nuclear. I write O2. Then I write an E, everybody. External limiting membrane. Then P2, photoreceptors and pigment epithelium. Now, I say to all my students, forget the E. External limiting membrane has no function in the retina, everybody. As I have just told you, it is a false basement membrane. It is not a true basement membrane, everybody. As soon as we forget that, our mnemonic becomes very easy to remember. ING, IOP into 2, everybody. So ING, IOP, ING, IOP. IOP is intraocular pressure, everybody. Yes or no? And that is how I am able to remember the 10 layers of the retina, everybody. Yes, I can just see this mnemonic whenever I want to remember and I can revise the layers, everybody. I for internal limiting membrane, it's the innermost layer. N for nerve fiber layer, G for ganglion cell layer. Then there will be two I's, everybody, inner plexiform, inner nuclear, two O's, everybody, outer plexiform and outer nuclear. Then photoreceptors and pigment epithelium. I say the pigment epithelium always at the last because epi means outside, that is the outermost layer of the retina. I hope we understand this, everybody. Nothing to understand. I hope we are able to learn this, everybody. Yes? Now that we know the names of the layers of the retina, and I hope you have spent 1 minute to remember the mnemonic and thus to be able to remember the names, let us see what happens in the retina. So everybody, as we know, retina is the neurosensory layer. Yes? So the function of the retina is to perceive light or receive light, everybody, which is a sensory energy, and convert it into the visual impulse. If I say the retina is probably the most inefficient structure, it has been formed opposite to what it should have been. What do I mean to say? See, everybody. Light, first of all, falls onto the cornea, passes the cornea, then will cross the lens, then will cross the vitreous, and then will fall on the retina. But in retina, what are the photoreceptors? Rods and cones. They are named photoreceptors because these are the cells which are going to receive light and are going to generate the visual impulse. Yes or no? We know the visual cycle, everybody, cis-rhodopsin, trans-rhodopsin. Yes? So the light has to travel all the layers of the retina, then go to the 9th layer, everybody. Yes? If I focus here, everybody see, the light will fall on internal limiting membrane, nerve fiber layer. It will cross all the layers and it will reach the photoreceptors. Then the photoreceptors, rods and cones, will generate a visual impulse, which will again go up, everybody. It will go up into the nerve fiber layer, everybody. Yes or no? So there is a two-way, everybody. The light comes in first, then the visual impulse goes out. Won't it have been better had the cornea been flipped? So the photoreceptors would have been the second layer, and then it would have been a unidirectional flow. So just musings, everybody. But that is what is occurring. That is what is occurring. Evolution has not taken place. Retina has not flipped as yet. So what is occurring? Light is traveling inside the retina first, coming into the photoreceptors. Photoreceptors have rods and cones. Rods and cones are generating the visual impulse, everybody, and that is why they are known as first order neurons of the visual pathway. Okay? Then the visual impulse is being transmitted from the photoreceptors into the inner nuclear layer. In the inner nuclear layer, everybody, we have cells called as bipolar cells. Bipolar cells are the second order neurons. Okay. Now, the bipolar cells transmitted further up to the ganglion cell layer. Ganglion cell layer, by the name is clear, consists of ganglion cells. So, ganglion cells are our third order neurons. Okay, everybody. Now, the visual impulse from the ganglion cell will go into the nerve fiber layer. I hope we understand this. All the nerve fibers, everybody, all the nerve fibers, they will collect to form my optic nerve. Yes or no? Optic nerve is the collection of the nerve fibers, everybody. So now my question to all of you, what is optic nerve? Ganglion cell order. Ganglion cells are the third order neurons. So what is optic nerve, everybody? Optic nerve should become the fourth order neuron. Yes or no, everybody? No. Yes, it is not the fourth order neuron. Optic nerve is also the third order neuron. Basic physiology, guys. Basic physiology. Do we understand this? Do we understand this? If not, let us see this, everybody. Everybody, when we draw a neuron like this. Yes or no? This is our cell body. These are the axons or the nerve fibers. So can I say the cell body is ganglion cell and the axons are nerve fibers? Collection of nerve fibers is optic nerve, everybody. So third order neuron, ganglion cells and the nerve fiber layer, both are the third order neuron. If we define optic nerve, how we define optic nerve, everybody? Optic nerve can be defined as collection of axons of ganglion cells. If we know this definition of optic nerve, I hope we are clear of why ganglion cells and the nerve fiber layer and the optic nerve, everything is third order neuron, everybody. Yes. Now we have read neuro-ophthalmology. So post this, we already know the visual pathway. Optic nerve goes out of the retina or the eye, everybody, then crosses optic chiasma, then becomes the optic tract, lateral geniculate body, then becomes the fourth order neuron, optic radiations, which relay into our occipital lobe in the visual cortex, everybody. Yes. So that is our visual pathway. I hope we are able to understand, everybody, that the first order neurons are rods and cones. You may find some discrepancies. Some of the authors say that the first order neuron are bipolar cells, everybody, and photoreceptors are nothing, everybody. But that is a wrong concept. Through various discussions, we have come to the answer that the first order neurons are photoreceptors. There is no confusion, there is no controversy. Please don't fall into this and keep on asking and troubling yourself over and over again. This is what I have taught. This is what is the answer, guys. Please don't worry about this. Yes? Now that we know this, we have encountered another name here, sir. We have encountered a name which is plexiform. Sir, what is the meaning of this word plexiform? So plex means synapse, everybody. If you put your mind to it, you will see inner plexiform is forming a synapse between the third order neuron, that is the ganglion cell, and the second order neuron, that is the bipolar cell. Yes or no? So between the order neurons, there has to be a synapse, and that synapse is in the plexiform layer. Similarly, if we focus at the outer plexiform layer, we would know that it is forming a synapse between what, everybody? The first order neurons, that is the rods and cones, and the second order neurons, that is the bipolar cells. I hope we are pretty clear about the basic anatomy of the layers of the retina, everybody. Yes? Now, to complete this further, everybody, let us just discuss some important points. The very important point is that the first site of generation of action potential, AP, are the ganglion cells. Are we confused? We are saying the first order neurons are photoreceptors, but we are saying the first site of generation of action potential is ganglion cells. See, photoreceptors generate local graded potential, which is conducted by or transmitted by electronic conduction. I am not saying that the photoreceptors are not generating the visual impulse. Yes, they are generating the visual impulse, but not the action potential. That is local graded potential, everybody. That is summating to the bipolar cells, and then the bipolar cells are transmitting that local graded potential to the ganglion cells, and it is ganglion cells which are actually producing the action potential. Yes, guys? Do we understand this very simply here? No confusion in this, everybody? Okay. Now, also remember that there are structural supporting cells which we call as glial cells. So the question is asked, what are the neuroglial cells, everybody, in the retina? So the neuroglial cells in the retina, as I have already told you, are Muller cells. Secondly, everybody, astrocytes. And thirdly, everybody, microglia. So these are the three main neuroglial cells in the retina, everybody. Yes? That's all about the basic layers of the retina, their names, everybody, and the basic visual pathway. Now, to understand the microscopic anatomy a little better, I am drawing a very simple line diagram for all of you. What have I drawn? Let's see. These are the inner 9 layers of the retina sandwiched together. They are known as NSR, or neurosensory retina. If we think about it, everybody, the inner 9 layers are ING, II, OO, E and P. P for photoreceptors. Photoreceptors generate the local graded potential. It goes into the inner nuclear layer, bipolar cells, goes into the ganglion cells, goes into the nerve fiber, optic nerve. Yes. So this part is called the neurosensory because this is generating the visual impulse. Yes or no? That means, in another way, I am saying that the outermost layer has no role in the generation of visual impulse. Yes or no? The outermost layer is pigment epithelium. The short form we write as RPE, retinal pigment epithelium. Okay. So what I understand through this is that the retinal pigment epithelium is not playing any role in the generation of the visual impulse. That is a function of the neurosensory retina, and that is why it is named so neurosensory retina. So does that mean my retinal pigment epithelium is a useless layer? Obviously not. Yes. So what are the functions of my retinal pigment epithelium? Let us see that. Number one, it has phagocytic function. And number two, it forms outer blood retinal barrier. What is blood retinal barrier? We will see in a minute. Let us go back to the image, everybody. When we saw the image, we saw that the inner 9 layers are everybody sandwiched with each other. But everybody, there is an empty space between the neurosensory retina or the inner 9 layers and the outermost layers. So my first question to all of you, what is the name of this space, everybody? This space is known as subretinal space, SRS. Why does it become an important piece of terminology, everybody? Because if we don't know this and if we hear the word subretinal space, what comes into our mind? Think about it, subretinal space. As soon as I hear subretinal space, I think that we are talking about a space below the retina. Yes or no? Subretinal. But actually subretinal space is not below the retina. It is actually in between the retina. I can show you this, everybody. That is how I remembered it. These are my inner 9 layers sandwiched with each other, neurosensory retina. This is my pigment epithelium and the space between them is subretinal space. Yes or no? So subretinal space is a misnomer, I can say. It is actually in between the retina, below the neurosensory retina, above the pigment epithelium, or a space between the inner 9 layers and the outermost layer of the retina, guys. Yes, guys? Now, we know the basic anatomy, the basic organization, the layers, everybody. Now let us get back to this word, blood retinal barrier. Now, we say that the pigment epithelium is forming the outer blood retinal barrier. What do we mean by this? See, below the outermost layer, what is there, everybody? Choroid. Outermost layer touches the choroid. Choroid has large blood vessels. Yes? We know that blood vessels can keep on doing transudation, exudation, inflammatory, vasodilation with leakage of cells, proteins, everything. So whenever any fluid is leaking, everybody, the fluid wants to find a space. If I tell a story, the choroidal vessels know that there is a space, subretinal space, where they want to leak all their fluid, everybody. Yes or no? What is preventing this fluid or this blood, everybody, from coming inside the retina? And that is the retinal pigment epithelium. That is why we say RPE forms the outer blood retinal barrier. Yes, understood? But if we are saying outer blood retinal barrier, that means there should be an inner blood retinal barrier. But obvious, yes or no? Yes. So blood retinal barrier, everybody, outer and inner. Outer blood retinal barrier, guys, is formed by retinal pigment epithelial cells. Inner blood retinal barrier is formed by endothelial cells of capillaries in outer plexiform layer, short form OPL, in outer plexiform layer. I hope we are clear about this, everybody. Simple concept, blood retinal barrier. Just like there is a blood brain barrier, we have a blood retinal barrier. Right, guys? And that's all about the anatomy of the retina. Gross anatomy, I hope we learned this. Optic disc, blood vessels coming on the temporal side forming an arcade, macula situated temporal to the optic disc as an avascular area, we can recognize it. There are 10 layers of the retina. We start from the innermost layer, which is the anterior layer, which touches the vitreous. I for internal limiting membrane, N for nerve fiber layer, G for ganglion cell layer. Then two I's, everybody, inner plexiform, inner nuclear. Two O's, everybody, outer plexiform, outer nuclear. Then E for external limiting membrane, P for photoreceptors, and P for pigment epithelium. We know the organization, everybody. Inner 9 layers, neurosensory retina. Outermost layer, pigment epithelium, separated by a space, subretinal space. Okay. Now, to complete the basic anatomy of the retina, everybody, let us see the blood supply of retina. So retina is a dual blood supply. The inner 6 layers are supplied by central retinal artery, and the outer 4 layers are supplied by short posterior ciliary artery. I hope we do remember this from our basic anatomy, where we have discussed the blood supply of the whole eye in detail, everybody. Short posterior ciliary artery is also the supply to the choroid, everybody. Also the supply to the sclera, everybody, posterior part. I hope we remember this, everybody. All the blood supply that comes into the eye is a branch of ophthalmic artery, which is a branch of the internal carotid artery. Yes or no? Now, as a special point, please remember that macula gets its main supply from central retinal artery. But in some cases, macula may also be supplied by cilioretinal artery, which is a branch of short posterior ciliary artery. Okay, everybody. So the main supply is from central retinal artery, but in certain individuals, we also see a supply from cilioretinal artery. Yes, I hope we are clear about just this simple fact, everybody, about the blood supply. Now, everybody, we know the layers of the retina, so we should be able to see them in a histopathology image, everybody. So this is what a histopathology image of retina looks like, everybody. Now, first of all, we should be able to determine that this is my vitreous. How are we able to determine this is our vitreous? How are we able to know which is the innermost part of the retina in the image, which is the outermost part of the retina in this image? So I always say the outermost layer is called, again, as everybody, pigment epithelium. So you will see some brown pigments deposited in a layer. So first of all, search for that brown dark area, everybody. So when I look, this is where I see a brown darkly pigmented layer. That means this is my retinal pigment epithelium. Yes or no? So now I know the orientation of my image, everybody, that we are talking about the choroid here, everybody. And that means this is my vitreous, everybody. Yes. Now I want to see the 10 layers of the retina. So what do I focus on, everybody? First of all, I have been able to find RPE. Now I know there has to be a ganglion cell layer in the innermost part. So I see a layer which has a lot of cells. This must be my ganglion cell layer. Then I know there is another layer which has a lot of cells, everybody, inner nuclear layer. So below the ganglion cell layer, I see another cells, inner nuclear layer. Then I see another layer with a lot of cells. This must be my outer nuclear layer. Yes or no? So just by looking at the various level of cells, I can identify my main layers. Now I just need to fill in the blank. Between ganglion cell layer and inner nuclear layer, I must have inner plexiform layer forming a synapse. This must be my what, everybody? Outer plexiform layer. This, everybody, this which you see, this is my internal limiting membrane. This is my nerve fiber layer. See, I'm filling the blanks, that's all, because I know the names of the layers, ING, I2, O2, and then what is left is E and P2. E, external limiting membrane, is a false basement membrane, almost invisible, so thin, everybody, and these are my photoreceptors. Okay, everybody. So how to solve this, everybody? You get an image, you get an arrow marked, everybody. You will get an arrow marked like this, everybody. They will say identify this layer, everybody. So how do you identify this layer? I will again repeat. First of all, find the pigment epithelium, everybody. Then see the three layers of nuclei, everybody. Ganglion cell layer, inner nuclear layer, and outer nuclear layer. After you are able to identify these four, everybody, everything else is a fill in the blank, and you will be able to do it in less than a 30 seconds, everybody. That is my promise to all of you. Yes. So you have to remember the names of the layers. That's what I say again and again. If you don't remember the organization of the retina, if you don't remember the layers, everybody, then all these kind of questions keep on becoming very difficult, everybody. This is all about the basic anatomy of the retina, everybody. This is your base for retina. If we don't know this, again I say, everything else becomes difficult. Now, as we have been reading in all the other chapters, after we know the basics, everybody, and before we move on to the pathologies, what we need to know. A patient comes to me complaining of loss of vision. I examine the cornea, no problem. I examine the lens, no problem. Vitreous, no problem. Everywhere there is no problem. That means the problem must lie in my retina. So I need to be able to examine my retina. Investigations needed to diagnose a case of retinal pathology. So that's what we will be discussing, everybody, now. The second part of our retina chapter, investigations of retina. Now that we are talking about the investigation, guys, what is the first investigation we will always do when we suspect a retinal pathology? See, always as a clinician, I want to be able to see the disease, see the pathology, yes? So I want to see the retina. Seeing the retina means what am I doing, everybody? I am doing fundus examination. Yes, there is nothing called retinal viewing, everybody. We all know fundus is a view of the structures of the posterior segment comprising of vitreous, retina and choroid. So I am examining the fundus first of all by the investigation known as ophthalmoscopy, everybody. So if somebody asks you what is the use of ophthalmoscopy, the simple answer is fundus examination, not retinal examination, everybody. Yes. Now, when we are doing ophthalmoscopy, we have two instruments. There are two types of ophthalmoscopy or two instruments. One is called as direct ophthalmoscopy and the second is simply called as indirect ophthalmoscopy. Now, first of all, everybody, when we are doing ophthalmoscopy, let us think we are trying to examine basically the structures of the retina. Let's say we are trying to examine the optic disc. What was the diameter of optic disc, guys? 1.5 mm, yes. Now, when the optic disc is so small, I know I cannot view any of the details in it. So, when we are doing ophthalmoscopy, we are trying to examine the retina, yes. Let's say in the retina, we are focusing at the optic disc, okay. Now, what is the diameter of the optic disc, everybody? Yes, 1.5 mm, yes. So, we know the optic disc is so small that we are not able to see any details at the optic disc. So what is my first wish? What is the first thing that I would want my ophthalmoscopy to do, everybody? I would want it to magnify the image so that I'm able to see the details properly. So that is my first question. What is the amount of magnification in each of the ophthalmoscopies, everybody? Direct ophthalmoscopy gives us, yes, 15 times magnification. Whereas indirect ophthalmoscopy gives us 3 to 5 times magnification. Okay. Now that we know that ophthalmoscopy will magnify the image, we know that we must be using a condensing lens during ophthalmoscopy. Yes. Now, do we use any condensing lens in direct ophthalmoscopy? The answer is no. We have a convex lens which is inside the instrument. Okay. So the instrument itself has a lens inside it which we can rotate and change the power for. But for indirect ophthalmoscopy, everybody, do we have to use a condensing lens? Yes. Because we are magnifying, the lens will again be convex. But what is the power of the lens used, everybody? Plus 20 diopter, everybody. That is a question which the examiners love to ask. Because for direct ophthalmoscopy, there is no external lens, no condensing lens that you are holding. It is inside the instrument, everybody. But for indirect, you need to know what power of lens to use to be able to do the investigation. Yes, I hope we are clear about this. Now, Now that we are using a condensing lens, everybody, I can say optics comes into effect. So when optics comes into effect, I can ask you the third difference, everybody. What is the type of image formed? What do I mean to say when I say the image form? Everybody, we have read in optics in class 11th and 12th that there can be two types of images, everybody. Either it can be real and inverted, or it can be virtual and erect. So for direct ophthalmoscopy, the image formed is virtual and erect. But for indirect ophthalmoscopy, it is real and inverted. Yes. How I remember it, everybody? I for inverted, I for indirect, everybody. Yes. Real and inverted, this much I know through my optics. Everybody, moving on. Next point of difference is this word, stereopsis. What is stereopsis, everybody? I hope you have gone through the chapter on squint, everybody. We have discussed the grades of binocular single vision. So stereopsis is grade 3 binocular single vision. That means I can say stereopsis is depth perception. But this depth perception is a function of binocular vision. Okay? Now, next point of difference. Let me write just 3 points of difference and then we will explain this. What is the distance of examination? Next question, everybody. What is the patient's position? For both direct ophthalmoscopy as well as indirect ophthalmoscopy, these are the 3 questions which we want to answer. Okay. So to answer these questions, everybody, I would presume or I would hope, everybody, that you've gone to your clinics and seen direct ophthalmoscope and indirect ophthalmoscope and seen these investigations being done. Because at last, these are core clinical questions. I hope you understand. Yes, core clinical questions can only be answered once you have actually done, or if not done, at least seen it. But a lot of you are saying we haven't. We are COVID babies. We have got admission in our MBBS during COVID. Probably we haven't had too much exposure to clinics. Even if we had the chance, we didn't go. Yes. So that is why we will be discussing these 3 points in clinical scenarios by a clinical examination of a patient. So guys, now that we are discussing ophthalmoscopy and we know that there are 2 types of ophthalmoscopes, direct and indirect ophthalmoscope, let us see this instrument. This instrument, everybody, is called an indirect ophthalmoscope. Okay? As I like to remember, this is worn over the head. There are 2 ways of earning money, right? One is direct, when you use your hands, mehnat karke. So we hold the direct ophthalmoscope, as we have seen in the other video, in our hand. But the other way is indirect, dhoka dhadi karke, kisi ko topi pehnana. Yes? So that is how I remember it. When you wear it over your head, everybody, you call it an indirect ophthalmoscope. Now, how do we do this investigation? As you see, first I have worn the indirect ophthalmoscope over my head. Then this, everybody, this part is the lens. As you will be able to see, this is a binocular instrument. Can you see, everybody? This viewing is binocular and then there is a lens situated. So I wear it over my head. I turn out the light in this. This is the light switch. I turn out the light, everybody. Then I pick up the lens. As we said, we need another convex lens along with our indirect ophthalmoscope. So this is the lens we use, everybody. This is a plus 20 diopter lens. As you can see, the power is written as 20D, 20 diopter. So now we are going to examine the fundus of the patient using both these instruments. I bring my indirect ophthalmoscope into focus. I hold the 20 diopter lens at an arm's length. So if asked the question, what is the distance of examination in indirect ophthalmoscopy? The answer is arm's length. We focus the light onto the patient's retina through the 20 diopter lens and we are able to focus on the fundus. We can examine the fundus all over 360 degree by asking the patient to look in different directions. Look up. So when I ask the patient to look up, because I am seeing a real and inverted image, I am actually looking at the retina, which is the inferior retina. Look down. When I ask the patient to look down,
I am focusing on the retina of the patient, I am actually looking at the upper part of the retina. I hope you have been able to understand on how to do indirect ophthalmoscopy. So guys, this is our second instrument, that is the direct ophthalmoscope. As you can see, this is a handheld instrument. So again, thus goes my story and my mnemonic. I hope you understand, everybody. Yes. Now, this is a self-illuminating. This is the battery power, everybody. This is the lens. So if I turn this, you can see light is coming out, everybody. Okay. You can see light on my hand, everybody. Yes. So this is the peephole, everybody, through which we are able to look at the fundus. This regulator changes the power of the lens. That is why we saw that in indirect ophthalmoscope, we were holding a 20 diopter lens, but in this, we don't need any other lens. We can change the power of the lens through this turn, everybody. Okay. So now, how do we use this instrument to examine the fundus of the patient? We close one of our eyes. We keep the instrument over one of our eyes. So if you look at me now, my right eye is closed and my left eye is open. The instrument goes over my left eye in front of this hole. Then I move as close to the face of the patient as possible. I adjust the power. You will see me adjusting the power through the knob, everybody. I adjust the power. I ask the patient to look straight ahead, everybody. And I end up examining the central part of retina of the patient. So now I can see the optic disc of the patient. Yes, now my optic disc is absolutely in focus. And it is an absolutely all right disc, guys. Okay. So when we are doing our post-graduation, there is a joke that be careful, otherwise you will end up kissing the patient in direct ophthalmoscopy. And I hope you were able to see why, guys.
Now that we have seen the clinical examination, clinically the direct ophthalmoscopy and indirect ophthalmoscopy being done, everybody, let us answer these questions. Stereopsis, everybody. Stereopsis will be present or absent for direct ophthalmoscopy. Direct ophthalmoscopy was a monoocular examination, as we just saw. So that means stereopsis will be absent. Whereas indirect ophthalmoscopy was a binocular examination. So we know that stereopsis will be present in this. Okay. Again, everybody, as we saw in the video, we are just writing it, everybody. Distance of examination. Direct ophthalmoscopy, I almost ended up kissing the patient. So we simply say as close to face as possible. Whereas for indirect ophthalmoscopy, it was, yes, it was an arm's length. What was the patient's position, everybody? Patient's position for direct ophthalmoscopy was standing. Okay. And here it was supine. The patient was lying down, everybody. Yes. So we can answer these questions very easily. We don't even need to learn this if we have seen that. So if you have the video in mind, if you have seen or if you have done that, these are irrelevant questions which are very easy to answer. Yes. Now, moving on, everybody, the differences between direct and indirect ophthalmoscopy. We move on to a very important point. Area visualized. Now, what do I mean to say by area visualized? See, I mean to say that we are doing ophthalmoscopy to examine the fundus. And fundus is a view. So, how much of area can I view? What do I mean to say? See, everybody, if I need to click photograph of, let's say, 100 students sitting together. Yes. In a class, there are 100 students sitting and I want to click a photograph of all the 100 students. So, I will need a large field of view. For a large field of view, my magnification has to be less. Yes. But if I need to click the photograph of only one of that 100 student, everybody, that means my field of view needs to be small. Field of view small means magnification high. Okay. So can I say magnification is inversely proportional to field of view? If I apply the same concept here, everybody, I know that because my magnification is higher for direct ophthalmoscopy, my field of view will be smaller. Yes, everybody. And that's what I am writing here. The area visualized in one word will be a smaller area. Whereas for indirect ophthalmoscopy, because my magnification is lesser, everybody, so I'm able to view the whole class, everybody. So my area visualized will be larger. We understand the concept? If you understand the concept, there are various ways of answering this question, everybody. First, I can say if I am visualizing a smaller area, what am I interested in? Am I interested in viewing the central part of the fundus or the peripheral part of the fundus? Obviously, all the important structures are located in the central fundus. That means direct ophthalmoscopy is visualizing the central part of the fundus. But once I am doing indirect ophthalmoscopy, because of my larger field of view, everybody, I will be able to view the central fundus. Plus, I will also be able to view the peripheral areas. Yes or no, everybody? Based on the simple concept that the magnification is lesser, so the area is larger. Now, the second way to answer this question, that's why I'm writing or, everybody. These are just different ways that the examiner can put you options. If I am viewing the central fundus, everybody, which parts of the retina am I looking at? Central fundus. The image we saw, the gross anatomy, everybody, we were looking at the central fundus, yes or no, central part of retina. We were able to look at the optic disc and we were able to look at the macular area. But if we are doing indirect ophthalmoscopy, we are looking at optic disc and macula. But we will also be able to see ora serrata. Yes. Third way to answer this question. You say, sir, why are you making our life so difficult? It is an area, just measure the area. I say, okay, let us measure the area. So the area that I can view is equal to 2 dd. The area I can view is larger, equal to 8 dd. What is dd? dd is disc diameter. Disc diameter, everybody. Yes. So 2 dd basically is 3 mm. One disc diameter, optic disc diameter is 1.5 mm. But when we are actually examining the fundus, we don't have a scale to measure the distance in mm, everybody. So we have to imagine how many optic discs will fit, everybody. So 2 dd means 2 disc diameters. 8 dd means an area equal to 8 optic discs fitting together in that area. I hope we are clear. And then the last way to answer this question is field of view, everybody, in terms of the degrees, everybody. So I can see 10-degree field of view. Here I can see around 45-degree field of view. Smaller field, larger field. Okay, everybody. So that's how it starts. Larger field 45 degrees, smaller field 10 degree, everybody. Yes or no? So that's the very important point. Area visualized, please remember, based on the magnification and different ways to answer this question. Lastly, everybody, direct ophthalmoscopy can not be done if hazy media, whereas we say for indirect ophthalmoscopy it can be done if hazy media. Okay, what do we mean by this hazy media? We are trying to visualize, guys, the fundus. So if the cornea has an opacity, if we have cataract, that means the the medium which is letting the light pass and we are able to see the fundus, everybody, if that is hazy, can ophthalmoscopy be done? Yes. But which ophthalmoscopy can be done, everybody? Indirect ophthalmoscopy, because the field of view is larger. Yes, because the field of view is larger. Let's say there is a central opacity, I will be looking through the periphery. If there is a peripheral opacity, I will be looking through the center. But in cases of direct ophthalmoscopy, because my field of view is smaller, if there is any opacity, any hazy media, everybody, direct ophthalmoscopy will not let us visualize the fundus. Yes or no? I hope we understand this. And that is all about the differences between two types of ophthalmoscopy, direct and indirect. I hope I have been making it abundantly clear that this is the first examination we will do. This is basically what a torch is to you, the direct and indirect ophthalmoscope is to an ophthalmologist. Yes or no? We are looking at your fundus through this, everybody. This is the most basic investigation. That is why we want you to have actually done it, everybody. Your CBME pattern, again, I say, asks you to develop some skills, everybody. This is one of the skills that all of you ought to have, everybody. And that is why we have done a clinical examination for you to be able to fix it in your mind, and you should also be able to perform it. Not correctly, but at least you should know the steps, you should know the way to perform it, everybody. Yes? Now, if you remember, we were examining the optic disc in glaucoma. Glaucoma is an optic neuropathy. So now for glaucoma, we were doing which ophthalmoscopy, everybody? We were doing direct ophthalmoscopy. Yes or no? Why were we doing direct ophthalmoscopy? Because we only wanted to look at the optic disc, only the central part of the fundus, everybody central part of the retina, and direct ophthalmoscopy will give us better magnification. But if I say I have a disease called retinal detachment, my retina is detached, which ophthalmoscopy would I prefer, everybody? Direct ophthalmoscopy or indirect ophthalmoscopy? Indirect. Yes. Why, everybody? Brilliant. See, this is my retina. It's not necessary that the retina detaches only from the center. The retina can detach anywhere near the ora serrata also. So that means when I suspect a pathology which can involve any part of the retina, I end up doing indirect ophthalmoscopy. I hope you will be clear. If I make a list, I will have to cover all the diseases in the retina here. So the basic fundamental is, if you want to look at the center, if you want a bigger magnification, you do direct. But if you want to look at the complete retina, everybody, you want to do indirect ophthalmoscopy. I hope I'm pretty clear about this here. Yes or no? Done, guys? No. That's our first investigation done. Moving on to the second investigation, everybody. The name of the second investigation is FFA. What is FFA, everybody? So the full form of FFA goes like fundus fluorescein angiography. Fundus fluorescein angiography. What is the use of this investigation? The name. What is angiography, everybody? Angiography is visualization of blood vessels. Yes. We are visualizing the blood vessels of the fundus by injecting which dye, everybody? Fluorescein dye. So we are injecting the fluorescein dye, then we are, everybody, measuring the fluorescence. So by measuring the fluorescence of the fluorescein dye, we are able to visualize our blood vessels, everybody. And that, in short, is FFA. Yes? We are interested in visualizing the blood vessels. The dye is fluorescein. But what do we do with this dye? We inject this dye in antecubital vein. 5 ml of 10% solution. Please remember that fluorescein dye is a water soluble orange colored dye. Okay, so we are injecting this dye into the antecubital vein. It is going into the ocular circulation through the ophthalmic vein. Then blue light is exciting the molecules. So blue light is being shown, everybody. Blue light will lead to excitation of fluorescein molecules, which will fluoresce at around 520 to 530 nanometers. Okay, everybody. So blue light will excite the fluorescein molecules. Blue light is around 460 to 465 nanometers. So due to the excitation, the fluorescein molecules will fluoresce at around 520 to 530 nanometers, and we will be able to see the fluorescence. That's as simple as FFA. Theoretically, it is all right, but practically, how do we see it, everybody? Let us see the images. So these are the FFA images. First of all, let us look at the normal FFA image. Now, why are we doing FFA, everybody? We are doing FFA to visualize the blood vessels. Why are we visualizing the blood vessels, or how are we visualizing the blood vessels? Because we know that the dye is going to basically, I can say, stain the blood. Blood is in the blood vessel. So we will be able to see all the blood fluorescing. That means we will be able to see all the blood in the blood vessels, and the blood vessels will be shining. If I can say, fluorescence means shine, everybody. Yes. So when I look at a normal FFA photograph, what do I look at? First of all, I look at the optic disc. Again, everybody, we need to see the basic anatomy. Then I look at all these blood vessels. Can you see all these blood vessels now, everybody, fluorescizing, everybody? Yes, all this white color, everybody. We can see all the blood vessels. We know that arcade is formed on this side, so this must be the temporal side. Yes. Now in the temporal side, we see an area in the center which is dark. Why is it dark? Because there are no blood vessels. Because there are no blood vessels here, this is foveal avascular zone. So there is no dye, and because there is no dye, this is dark. So I can say basically I am looking at my macula. Yes. So when I see a normal FFA, I can see two things: whether my blood vessels are normal or not, and whether my macula is normal or not. So if I ask you what are the uses of FFA, I think I will be able to explain you two things here. First of all, we can diagnose vascular disorders. And secondly, we can diagnose macular disorders. Vascular disorders and macular disorders. Now you're saying, sir, how vascular disorders? We don't understand. Let us understand them. Again, I show you the normal image. See the normal image. The blood vessels are shining, everybody, with the dye, white in color shining. Had there been some problem in the blood vessels, what would have occurred? Let us see the problem, everybody. Let us see the first problem in the blood vessel. See this image, everybody. Again, an FFA image. But in this FFA image, what do we see? We see that this blood vessel, everybody, is fluorescing, yes. But somewhere here, there is a blot of fluorescence. Again, here there is fluorescence, there is fluorescence. What is this telling us? This is telling us that blood must be pooling in this area. Because the blood is pooling, that is why this area is becoming hyperfluorescent. Yes or no? That means my blood vessel must be leaking blood. There must be some kind of hemorrhage, everybody. There must be some kind of leakage occurring from the blood vessel. If we see the normal FFA again, you will see that the blood was inside the blood vessels. There was no leakage. Only the blood vessels were fluorescing. Do you understand what I'm trying to say? See, at last, again, I'm saying the fluorescent dye is staining the blood. So wherever there will be blood, there will be fluorescent dye. So at all these areas, everybody, 1, 2, 3, 4, 5, 6, everybody, there is some kind of fluorescence occurring. That means there is some kind of leakage occurring from the blood vessels. So we know it is some kind of a vascular disease. The other form of an abnormal vascular FFA can be blockage, everybody. Let's see another image. In this image, again, let's try to see clearly. This is my optic disc. This is my blood vessels going superiorly, all right. See, everybody, all these blood vessels going. Inferiorly, you can see these blood vessels getting filled with dye. But if we focus here, everybody, this much of blood vessel is filled with dye. Its branch here is filled with dye. But all these blood vessels are not filling with dye, everybody. That means at this point, everybody, there must be some kind of a blockage. If I clear it out for you, everybody, I hope you can see that this must be the point of blockage. And that is why all these blood vessels, everybody, they remain without the dye in it, everybody. So that means it can be a case of central retinal artery occlusion or central retinal vein occlusion, some kind of vascular occlusion. I hope you understand how FFA is helping me diagnose vascular disorders, either by blockage of a blood vessel or by leakage from a blood vessel. So very simply, I can say vascular disorders can be leakage disorders or blockage disorders. Am I making myself very clear here? Yes? Now, how do we diagnose macular disorders, everybody? As we just now said that on a normal FFA, macula appears dark. Why does macula appear dark? As there is a zone called FAZ, foveal avascular zone. Now, if I show you an image, everybody, see the normal image, macula is dark. But if we see this image, everybody, again, let us go through the anatomy. First of all, this is the optic disc. These are the blood vessels. Temporal side. This area in the center where there is no vessel should have been dark. But in the center of the macula, there is leakage of dye, everybody. If there is leakage of dye at macula, it is telling us that there is some kind of problem occurring at the macula. So I can say that this must be some kind of macular disease. What macular disease, blah blah blah, we will read it later on. But here we are trying to understand whether it is a normal FFA or an abnormal FFA, and what are the uses of an FFA. I hope we understand that we can diagnose vascular disorders or we can diagnose macular disorders. Macular disorders based on the fact that macula should normally appear absolutely dark, but in these cases there is some kind of leakage. Okay, macular disease, revising the images, everybody. We can see here some kind of blockage inferiorly. We can see a lot of leakage here, everybody. And this is my normal FFA. Done, everybody? Fundus fluorescein angiography. Let's move on to the next investigation. The next investigation is ICGA. What is ICGA full form, everybody? Indocyanin green angiography. ICGA. Again, guys, we are doing what? Angiography. We are doing visualization of blood vessels. But instead of fluorescent dye, now the dye has become indocyanin green. That's all. So this is just a variant of FFA, I can say. ICGA is better to visualize choroidal circulation. See, we are talking about the fundus overall here. So fundus has two vascular structures, retina as well as choroid. Retinal vasculature was very clearly seen on FFA, but what if there is a choroidal pathology, everybody? We want to examine the choroidal vasculature, then FFA is not the correct investigation, everybody. Instead, what we end up doing is ICGA. Now the question is, why is it better to visualize the choroidal circulation? The answer to that is in 2 points. A, it has better penetration. It has better penetration as ICG fluoresces at 805 nanometer. Yes, and thus this 805 nanometer light is able to pass through the pigment epithelium, everybody. Retinal pigment epithelium blocks a lot of light, everybody, when it is at fluorescing at 520 to 530 nanometer, everybody, the fluorescent dye. But because my ICG fluoresces at 805 nanometer, it is able to cross the pigment epithelium and thus visualize the dye in the choroidal circulation. Secondly, the dye has better retention. It has better retention as it is 98% protein bound. And these are the two reasons that we say that it is better to visualize the choroidal circulation. But there is a side effect, that it is contraindicated in patients with iodine hypersensitivity. The name of the dye should yourself tell you about the fact that iodine will have problem. It is indocyanin green, everybody. So that is all about ICG, not done for retina, everybody, but for choroidal circulations. Moving on to the next investigation. B-scan ultrasonography, everybody. Now we are on to USG ultrasonography. We must have read in radiology, everybody, that there are different types of ultrasonography: A scan, B scan, M scan, C scan, everything, everybody. Here we are discussing B scan. What is the full form of B, everybody? B for brightness. Okay, so we are discussing brightness scan ultrasonography. Brightness scan ultrasonography uses probe with 7.5 to 10 megahertz sound waves, or ultrasonic waves, I can say. B scan uses 7.5 to 10 megahertz ultrasonic waves. Now, what do ultrasonic waves do or ultrasound do? They generate echoes. Yes or no, everybody? That's the basic principle. If I talk in very simple layman language, that is the principle of ultrasonography. We are firing ultrasonic waves, they are generating echoes, everybody, and those echoes are getting recorded. In B scan, these echoes get recorded as dots. Okay, so the higher the echo produced by a structure inside the fundus, everybody, the brighter it will be. Yes, so I say when I'm examining the B scan, there can be two types of impulses I get. hyperechoic, or I can say hypoechoic slash anechoic. Hyperechoic will appear bright, or I can say white, brightness is white. Hypoechoic will appear black or dark, everybody. Yes. So when we are doing an ultrasonography, everybody, remember about pregnancy, everybody. All of us have seen a lot of movies, everybody, in which we have seen pregnancy ultrasounds being done. Even if we are pre-final students right now, if we are not, if you have not read OBG, everybody. Yes. So we know that while doing an ultrasound, we see something white, we see something black. So what is black? Black is something which is not echoing out, everybody. So it is hypoechoic or anechoic. And white is something which is giving the echoes, high echoes, everybody, hyperechoic. Okay. Now, radiology will use a lot of hyperechoic, hypoechoic. But for us to understand the B-scan ultrasonography, I use simply two words, white and black. Okay, everybody. When I see a B-scan image, which is a normal B-scan image, first of all, normal B-scan image, I look at the fact that this looks like an ultrasound. Yes, this looks like an ultrasound. Yes, I know. And this is an ultrasound of the eye. First of all, what we are able to see is a white area, hyperechoic area, which is the lens. Then we see a complete black area, that means it must be anechoic or hypoechoic, that is vitreous. And then posterior to vitreous, based on the anatomy, we again see a white area, which must be retina anteriorly and choroid posteriorly. Yes or no? So that means when I look at a B scan, I am first of all focusing on what should be black and what should be white. So black should be vitreous, white should be anteriorly retina, posteriorly choroid. And in the center here, you see a shadow of the optic nerve, everybody. Okay, everybody? Forget the optic nerve here. We are focusing on black is equal to vitreous, white is equal to retina and choroid. Now, when I see a B scan abnormal photograph, that is what I want to see first. Where is the abnormality? Is the abnormality in the black part or the white part? Okay. So let us see, everybody, an image of B scan. Let us try to understand whether it is normal or abnormal. Everybody have a look at it. Lens. Okay, not bothered. This is my vitreous. Okay. This part, everybody, white part, retina and choroid. This part, everybody, what is this? See, this is attached to this. And it has become detached. Do you understand what am I doing, everybody? If I draw a line here, everybody, this must have been my retina. See, this must have been my retina. But in this part, my retina, the anterior portion of the white has become detached. So that means I must presumably be looking at retinal detachment. Am I clear? White part has detached, white part anteriorly is retina, so this is retinal detachment. And that is how simply I diagnose such a case. Okay, everybody? Let's see this image, everybody. In this image, what do we see? Again, we see the lens, we see the retina here, we see the choroid here. Then in the center, all this is vitreous. Vitreous is supposed to be completely black, but what do we see now? We see that the vitreous has developed some hyperechoic lesion, some white part, if I can say. That means it is a vitreous pathology. This much is clear, everybody. Now a little bit of radiology comes, or a little bit of ophthalmology comes. The only disease that you will study in vitreous per se is vitreous hemorrhage. And if you have read radiology, you know that blood is hyperechoic, everybody. So this is blood collection in the vitreous, and that is why I can say that my diagnosis must be vitreous hemorrhage. I hope I am being clear here. I don't need to know anything about radiology. I just need to first of all find out the location of the pathology, white part or black part, everybody. Yes, and that is how I remember B scan. In B scan, I always remember that black is vitreous, whereas white is anteriorly my retina and posteriorly my choroids. Okay, everybody? Yes, sirs. Now, after we know how to see a B scan, my question to all of you is very basic actually. My question is, why am I doing B scan ultrasonography? Why do I need to do B scan ultrasonography? You are saying, sir, to see vitreous hemorrhage. But won't I be able to see vitreous hemorrhage when I am doing ophthalmoscopy? Vitreous, instead of being transparent, will be filled with blood, so I will be able to see a complete red vitreous. Ophthalmoscopy is for fundus examination. I will end up seeing the vitreous, everybody. Yes or no? Do you understand what I am saying? Sir, retinal detachment. If my retina is detached, again, when I do indirect ophthalmoscopy, I told you that for retinal detachment, we will do indirect ophthalmoscopy. I will be able to see the retina detached, everybody, when I am doing ophthalmoscopy. So again, the question comes, why am I doing B-scan? Sir, to confirm. What do you mean by to confirm, guys? If I don't believe my eyes, then what is the use of being a clinician? Why am I doing B-scan ultrasonography? Think about it. I have already given you a clue. We do ultrasonography in pregnancy. Can you draw some correlation from there? Can you? No? So can you see an embryo or a baby developing in utero with your eyes? Can you put your eye over the abdomen and see the baby developing, everybody? No, nah. So we are doing basically an ultrasonography to see the areas which we cannot see with our own eyes. So now the question comes, fundus we can view with our own eyes. But what if we have a complete cataract? You get the logic now, I hope. If we have a complete cataract, a mature cataract, everybody. Mature cataract means opacity completely throughout the whole lens, everybody. Will I be able to do direct ophthalmoscopy? Will I be able to do indirect ophthalmoscopy? No. So in cases of any media opacity, again, everybody, I come there, media opacity, everybody, either a complete corneal opacity or a complete lens opacity, I will not be able to visualize the fundus through ophthalmoscopy. And that is when I will need to do B-scan ultrasonography. Okay, everybody? So that's what I'm saying here. B-scan ultrasonography done if complete media opacity making ophthalmoscopy difficult. Okay, media opacity means either a corneal opacity we are talking about or a cataract we are talking about. Okay, everybody, I hope we are clear, everybody. So that means please don't ever say that B-scan is the investigation of choice, everybody. It is not the investigation of choice. It can only be the investigation of choice in such cases when there is a complete media opacity. Apart from that, if I ask you what is the investigation of choice for RD, don't say B-scan. I hope you get this concept. This is important because as students, we are primed somewhere to answer always X-ray, MRI, CT scan, ultrasonography as investigations of choice. But for retina, the investigation of choice will almost always be what, everybody? I hope you understand ophthalmoscopy. I can see with my own eyes. I will like to see with my own eyes. Moving on to the next, everybody, investigation number 5, OCT. So what is OCT, everybody? OCT is optical coherence tomography. Optical coherence tomography, everybody. As soon as I write coherence tomography, I hope we are understanding that we are talking about CT scan. Basically, we are talking about CT scan of the eye. Yes? Now, again, radiology a little bit. If we know it, if we don't, then we are writing here. What is the principle of CT scan or OCT? It is low coherence interferometry. Yes? All of us should know about CT scan, everybody, radiology topic. What we are discussing here is what is the use in the eye. So my question again to you, why are we doing CT scan over an ultrasound? We have already seen that we could see a retinal detachment and or vitreous hemorrhage. That means retinal pathologies in our ultrasound. So what is the further use of a CT scan? This is a general question, nothing related to ophthalmology, everybody. So ultrasound was showing us the structures, but they were not showing us the layers, everybody. Yes, we were able to see the retina was detached, but we couldn't see the layers of the retina. So basically, if we want to do a biopsy, optical biopsy, yes or no, that is the word we used, optical biopsy. If we want to see the microstructure, everybody, that is when we do a CT scan. Okay, so let us see what an OCT looks like. So this is the image of a normal OCT. You will be able to see that all the layers are marked. Are you expected to know or able to determine each layer on OCT, everybody? Nothing, not even close to it. Okay, all you need to know is that this is an OCT and some basics of OCT. What are the two basics of OCT, everybody? First of all, we should see that fovea appears like a depression. everybody, you will be able to see this is my normal retina. But where the fovea is, it is a depression, everybody. Fovea will appear like a depression because in the foveola, that is the center of the fovea, ganglion cell layer is absent. I hope you remember this through your anatomy. If not, then I have told you here. Yes. Secondly, we should be able to determine again the orientation of the retina. For that, we always see the outermost layer RPE is red in color. The outermost layer RPE, everybody, that means this layer must be my RPE. Okay. So if we are able to identify two things, number one, that my fovea is a depression and my RPE is the outermost layer, we will be able to discuss basic pathology diagnosis based on OCTs. Again, OCT can never be the investigation of choice. Whatever I am doing on OCT is for confirmation. I will be able to see the problems on ophthalmoscopy. Only when I am concerned about the layer of pathology, that is when I am doing OCT. Yes, guys? 5 investigations.
The sixth investigation, everybody, that we can do to examine a case of retinal disease is called as ERG. What is the full form of ERG? Electroretinography. Electroretinography. Okay, everybody? If you focus on the name, you understand this. Let's see, everybody. Graphy means some kind of a graph. Electro means some kind of an impulse. An impulse which is being generated by retina means retina. So retina is generating an impulse which I am recording as a graph. So does retina generate any impulse, visual impulse? Yes. So this is basically a record of the visual impulse generated by the retina. Am I clear? If I twist it and say it in another language, when the retina is producing the visual impulse, is it working or not working? Meaning I am trying to ask you, is this an action potential or is this a standing potential? We know this is an action potential, yes or no? So ERG is a record of action potential. Can I say this? Then if somebody asks you, what is the source of this ERG? So you know the whole retina works together, all the layers of the retina work together to generate the visual impulse. And that is why the source of ERG is said to be pan-retinal. Yes? Now, if it is a graph, you should know how the graph looks like. So I'll just draw a crude graph, very simple graph for all of you, everybody. We have a small negative wave, then we have a large positive wave, and then another small positive wave. Okay? So simply, this is known as the A wave, this is known as the B wave, and this is known as the C wave. Ophthalmologists are simple people, ABC, we don't know why PQRS. दिल से सोचे तो PQRS बना, यहाँ से सोचे तो ABC बना. Yes, ABC. Now we know this is a graph of a normal ERG. Okay, but each wave must be generated by some specific cell or layer. That is the question that the examiners ask you. A wave is generated by photoreceptors, hyperpolarization. B wave is actually generated by Muller cells. But Muller cells are not conducting cells. So it is conducted by bipolar cells. Am I clear, everybody? Yes. So some books write only the fact that B wave is generated by bipolar cells. That is correct to a degree, but if you want to go in detail, they are actually generated by Muller cells, only conducted by bipolar cells. C wave is a late positive wave due to the metabolism which is occurring in the retinal pigment epithelial cells. Okay, everybody? So A wave, B wave, C wave, and their respective cells and layers. Okay. Now, apart from the normal ERG that is drawn on your screen right now, there are some special types of ERG. Let's see them, everybody. Special ERGs. The first type of special ERG is ERP, early receptor potential. Secondly, multifocal ERG. Okay, two names. What is common between these two names is that both these are generated by only cones. Rod cells have no role in the generation of any of these two special types of ERG. Thus, I can say that they can actually be used to test my macular function. Why, everybody? Cone cells are press. Cone cells are maximally present at the fovea or macula. So basically these are an indirect macular function test. Yes. Thirdly, pattern ERG. Pattern ERG, a special type of ERG. It is used to diagnose glaucoma, as it records responses from ganglion cells. Ganglion cells, basically it is showing me the or correlating with optic nerve function. Why, everybody? We already know that optic nerve is the collection of axons of ganglion cells. Yes. And what is damaged in glaucoma, everybody? The optic nerve. So indirectly we are saying pattern ERG is a function for diagnosis of glaucoma because ganglion cells are generating this type of ERG, pattern ERG. Am I clear, everybody? That's all about my investigation. ERG, if you focus, basically we are trying to find out the function of the photoreceptors through this mainly. Yes or no? Now, the last investigation, everybody, that can be done for evaluation of a retinal disease is called as EOG. ERG, no, EOG. What is the full form of EOG? Electrooculography. Electrooculography. Now an impulse is getting generated by the whole eye, I am saying, and I am recording it as a graph. Okay, everybody? Now, if I close my eye, is my eye generating an impulse? I will say yes. What kind of impulse, everybody? Standing potential. Yes. So EOG is a record of standing potential. And this standing potential, if you ask me what is the source, the source is actually only two layers, the photoreceptors and retinal pigment epithelium. So the last two P's, everybody, photoreceptors and pigment epithelium. Yes. Why does EOG occur? Why is this standing potential produced? This is produced due to the voltage difference across the apical and the basal membrane of the retinal pigment epithelium cells. And that is why we say only two layers are contributing to it. So I can say indirectly that EOG is helping us to diagnose the diseases of outer retina only. Am I clear? Done? Responses of EOG are measured as R-dense ratio. Responses from EOG are measured by something known as R-dense ratio. So what is R-dense ratio, everybody? Light peak divided by dark trough. R-dense ratio. Nothing difficult, guys, very easy. What is light peak? What is dark trough? First of all, we record the EOG under bright light conditions. The highest value that we get in a lighted condition is called light peak. Then we record EOG under dark conditions. So the smallest value that we get in dark is called dark trough. You understand, everybody? So light peak, the highest value, dark trough, the lowest value, is divided, gives us the ratio R-dense ratio. Normally this ratio should be greater than 1.85, or if I say in terms of percentages, 185%. Okay, everybody? If it is lesser than this, that means there is some problem in the outer layers of the retina, mainly photoreceptors, everybody. Okay, no confusion. So these are the 7 investigations, everybody, that can be done to evaluate a case of retinal pathology. We will keep using these, we will keep referring to these when we discuss the pathologies of the retina or the diseases of the retina. You need to be smart to be able to understand what should be the investigation of choice, why we are doing each investigation. Ophthalmoscopy always the first to be done because we are visualizing the retina. Central or peripheral, that's the thing that you need to remember. We are doing FFA in cases of vascular or macular pathologies. We are doing ICGA only in cases of choroidal circulation pathologies. We are doing OCT when we need to see the layers. So it can never be the investigation of choice. It is always a substitute investigation to confirm my diagnosis. B-scan when there is an opacity in the media, cataract or this. ERG, EOG, photoreceptor problem. Am I clear, everybody? That's your small synopsis of the investigations. You need to remember these points. Using this, we will discuss the pathologies of the retina.